Well, that was my topic in this last meeting in COSTEM 2022. So I think that I would differentiate that in two different settings. So first of all, the initial indication that we had for CAR-T in patients with relapsed refractory diffuse large B-cell lymphoma. So in this case, the three phase 2 pivotal trials were looking at patients failing at least 2 prior lines of therapy. In this specific setting, let's say they were potentially fighting against the role of allogeneic stem cell transplantation in relapsed refractory diffuse large B-cell lymphoma, because allotransplant has been, in most of the cases, considered for those patients that relapse after an autologous stem cell transplant. So that would be a third-line treatment. So the long-term results of the three phase 2 pivotal trials basically indicate that there is a significant proportion of patients that can eventually be cured with CAR-T in this specific setting. So we have a kind of plateau in around 40% with 2, 3, or 4 years or even more follow-up, so indicating that probably most of these patients are going to be cured. This percentage of potentially cured patients is not different from the one that we can achieve with an allogeneic stem cell transplant. But if, let's say, if we consider CAR-T, let's say, the preferred option, we have to say that for CAR-T, we don't need a donor available. We don't need to have the disease in partial remission or eventually complete remission, which is a requirement for allogeneic stem cell transplant. Then the non-relapse mortality is lower than 5% in patients being treated with CAR-T. This is not the case in allogeneic stem cell transplant. We are looking at a non-relapse mortality between 15 and 20%. And finally, although we don't have a huge long-term outcome of patients being treated with CAR-T, the reality is that the quality of life and long-term issues with CAR-T are significantly lower than with allogeneic stem cell transplantation, where quality of life can be significantly impaired with the development of chronic GVHD and opportunistic infections. I mean, because of all these pros and cons, the reality is that the numbers of allogeneic stem cell transplants have significantly decreased all over the world, not only, let's say, in US, having, for instance, the CIBMTR registry as an example, but also in Europe, that we are 2 years, let's say, behind US with respect to the use of CAR-T outside prospective clinical trials. So in Europe, also the numbers of allogeneic stem cell transplantation are decreasing, and basically these treatments are being substituted in many cases by treatments with CAR-T. If we go to the second-line treatment strategy, and here CAR-T would be, let's say, playing a role against autologous stem cell transplantation, which for transplant-eligible patients is the standard of care for those patients with primary refractory disease and early relapse. We have the positive results of 2 out of 3 prospective phase 3 clinical trials that have already been published and that were presented at the last ASH meeting. And ZUMA-7, that has been the trial that has given the indication both by the FDA and the EMA of Axicabtagene, and then the Transform trial that has given the indication by the FDA to liso-cel, indicated that at least with the design of the 2 prospective clinical trials, the use of CAR-T was able to significantly improve event-free survival in front of salvage treatment strategies, so salvage chemotherapy plus autologous stem cell transplant in patients with primary refractory and early relapse diffuse large B-cell lymphoma. And event-free survival was the primary endpoint for both prospective clinical trials. Also, the overall response rate and complete remission rate were higher in those patients being treated with CAR-T. The results were not mature enough, of course, for overall survival, but it seems that overall survival might also benefit CAR-T in front of the standard of care. And in terms of quality of life, the quality of life of patients being treated with CAR-T, both in SUMA-7 and Transform, was better than the quality of life of patients being treated with the standard of care. In this sense, I think that we are still here early days, but the numbers of autologous stem cell transplantation, I think that they have started to decrease in US. And in addition to that, and that's important, the scientific guidelines, so NCCN guideline for relapsed refractory diffuse large B-cell lymphoma already includes several months ago the possibility to use Axicabtagene as second-line therapy in patients with primary refractory or early relapsed diffuse large B-cell lymphoma. And in the BMT guidelines, the last version of the indications manuscript that was published in March this year in BMT, although DIMA just recently approved Axicabtagene, and of course in Europe we have to go for individual reimbursement process in the different European countries. The BMT guidelines were also changed to introduce the concept of CAR T cells being the standard for patients with primary refractory and early relapse disease, while auto-transplant that has been for many, many years the standard of care for patients with primary refractory or relapse disease, if they achieve second response, has gone to a clinical option when talking about those patients with early relapse. So I think that basically because of all these issues, probably CAR-T will overcome or will be the preferred choice of therapy for the vast majority of these patients.